So just to give a kind of overview of what I'll talk about. First, for anyone who's trying to Google what SCAD is, I will tell you what that is and what it entails. We'll talk a little bit about how it differs from diverticulitis and inflammatory bowel disease, how it's similar. We'll look at some of the endoscopic diagnosis of SCAD and how to manage it. So what is SCAD? As Dr. Grant said, it's segmental colitis associated with diverticulosis. So diverticular disease classically presents as inflammation stemming from the diverticulum as diverticulitis, which is what most of us know. Segmental colitis associated with diverticulosis is inflammation of the interdiverticular mucosa, generally more chronic, with characteristic sparing of the diverticular openings. Because it's always with diverticulosis, this is almost always limited to the sigmoid with rectal sparing. Clinical presentation, typically these are older males. They generally present with lower abdominal pain, diarrhea, painless rectal bleeding. So oftentimes this is a diagnosis that's seen endoscopically when they're undergoing endoscopy, looking for cancers based on these symptoms. Really distinguishing it from diverticulitis, there's generally no fever, no leukocytosis. They don't have any nausea or weight loss associated with these endoscopic findings and the GI symptoms. Morphologically, when you look at it, as we'll see, it's pretty similar to inflammatory bowel disease. There's not great data on this. Prevalence estimates say that it's up to about 4% of patients who are undergoing colonoscopy that this is found. And in patients with diverticula, up to 11% of them, based on some studies, may have this diagnosis. So incidence is about 4 in 100,000. Pathogenesis is unclear, thought to be due to the muscular hyperplasia of diverticulitis causing mucosal prolapse or ischemia leading to the chronic inflammation. Traditionally, this has been considered part of the diverticular disease spectrum, lumped with diverticulitis. However, as more research has been done into the topic, it appears as though it's actually more related to inflammatory bowel disease. It looks like it and it acts a little bit more like it. And so there's this ongoing debate amongst people who study this, whether that's its own disease, whether it's a subset of diverticular disease or a subset of inflammatory bowel disease. So we'll kind of look at kind of where this falls into it. So diverticular disease or diverticulitis and SCAD, similarities, generally older patients. It affects similar areas of bowel because it's associated with diverticulum. It's limited to areas of diverticulum. And there's endoscopic sparing of the normal non-diverticular bowel. Differences, endoscopic findings in SCAD are fairly characteristic, as we'll see. Diverticular disease is nonspecific. As mentioned, there's no leukocytosis, no fever associated with SCAD. There's no pericolonic inflammation seen on CT scan, so these patients generally have normal imaging as opposed to what we classically see in diverticular disease. And histologically, SCAD is more closely related to inflammatory bowel disease, and there is TNF-alpha overexpression in SCAD as well. Which leads us to, is this the same thing as IBD? Similar segments, TNF-alpha, it looks similar on endoscopy, the histology is similar, and it does respond to mesalamine. However, the difference is SCAD typically is older patients as opposed to kind of the bimodal distribution, younger patients of inflammatory bowel disease. SCAD is limited to only areas with diverticulum, so usually rectal and proximal sparing. And SCAD tends to be much more benign than inflammatory bowel disease in terms of complications and relapse. So how is this diagnosed? Classically, as I said, the finding is inflammation limited to the sigmoid and descending colon in areas of diverticulum, and there's clear sparing of the diverticular orifices. So you see inflammation, and the white arrows mark the diverticulum, which are clearly separate from where that inflammation is. There's been a good amount of research into how to classify this and what the findings are. There are 4 types of SCAD which have been described, A, B, C, D. A is just on folds, you have small little areas of inflammation. B and D are ulcerative colitis-like. D is just a more severe version. And C is more Crohn's-like with isolated aphthous ulcers. You can see histologically, the findings are very similar to what you'd find in ulcerative colitis and Crohn's disease, and all of these have diverticular sparing, although in D it may be hard to kind of see those diverticular sparing just because of the severity of disease. One study which looked at 92 patients carrying this diagnosis showed the breakdown of these types. A is more common than B, all the way down to D. You can see diarrhea is the most common symptom overall. And based on the breakdown, they found that type A and C were generally less severe than types B and D, which were a little bit more severe in terms of relapse and symptoms. So how do you manage these things? The way we manage it, or the way it's managed, is basically mainly based off of case series and clinical experience managing diverticular disease and inflammatory bowel disease. There are some reports that show that without treatment, patients totally cure themselves and have no relapse. Medical management is usually enough to get remission in these patients. Surgery is rarely used and used for refractory patients or patients who become steroid dependent. And most of the authors that describe this say that if you're considering surgery for this diagnosis, you should reconsider your diagnosis because they probably have inflammatory bowel disease. There have been several algorithms proposed. One of the earlier ones, which is kind of based on a combination of diverticular disease and inflammatory bowel disease, uses a first-line treatment of antibiotics followed by mesalamine with a maintenance of mesalamine. They have the second line, which includes steroids and probiotics, which have shown pretty good results. And then third line is prednisolone and surgery. With the advent of the different categories with type A, B, and C, there have been proposed treatments based on the actual diagnosis, with the type A and C being the less severe, so they're treated just with mesalamine, and type B and D being more severe, adding in the steroids. And then most of these do involve a mesalamine maintenance. And you can see down at the bottom that for people who fail, you add in prednisone or stronger steroids, and then the final line is considering steroids. Or there's a note that says consider TNF-alpha inhibitors. There's a few studies that show that because of the overexpression of TNF-alpha, people have tried things like infliximab, and there have been some promising results. However, it's fairly limited based on the data. Outcomes. As you can see, with only 27 patients, there's not great data in terms of what the actual outcomes are. This one paper looked at patients who were treated following the algorithm that I just showed you with the 4 different types. So all patients with type A, B, and C had remission at 4 weeks with mesalamine or steroids based on whether they were A, B, or C. In type D, of the 4 patients, 3 of them were in remission at 8 weeks, and 1 did require escalation. The 5-year results of the same patients, they were down to 25 patients who were included. The type A, 6 of them who were on maintenance therapy, only 1 recurred during that period. 4 patients refused maintenance therapy, 2 recurred, 2 did not recur. Of type B, 3 out of 8 recurred while on maintenance therapy. Type C, all patients were in remission, going along with the type A and C or more benign disease. And type D, the most severe, 4 patients and half achieved remission with addition of prednisone, and half required azathioprine. So all 4 of those recurred within 5 years. So just to summarize, this is an unusual diagnosis, especially for surgeons to see. It's classic characteristic inner diverticular inflammation. Because it's only related to diverticular bowel, it's limited to the sigmoid. The rectum is classically spared. Recent data and recent studies have shown that this is probably much more closely related to IBD than diverticular disease. There's 4 subtypes, which correlate to the histology, the severity, the endoscopic findings, and may drive treatment, depending on whether you should just do mesalamine or steroids. The management is similar to IBD, as we've seen, and surgery is the very last line, and take care before you're operating for SCAD that you're not operating on something else.
I had a question. If you are doing a colonoscopy and you see some of those findings on let's say a screening colonoscopy in that sigmoid colon, what's your sort of assessment on that? Let's say an asymptomatic patient, would you?
You should biopsy it. You want to make sure that it's not IBD. It could lead down a road of getting a diagnosis of IBD if it's not actually there in an asymptomatic patient. In screening colonoscopy that doesn't have symptoms, you always wonder, is this just from prep? Is this just an incidental finding? So you kind of need to piece everything together. Typically, I think with the absence of symptoms, I would not get too excited about it.
Thanks. Yeah. Thanks very much.